Hello, and welcome to Cutting Edge Pain Relief. Today, I am talking to our viewers about pain, depression, and neuroplasticity. So, fancy last word, first two pretty evident. So, what exactly are we talking about today? What we're talking about is how pain and mood disorders, meaning depression, anxiety, really go hand in hand. And a lot of times, as physicians, nurses, healthcare providers, we don't really validate that and we don't explain why those things are an issue and how there's real value that's there. If we haven't met, I'm Dr. Orlando Landrum, an interventional pain and regenerative medicine specialist. And one of the things that we try to do on this channel is to try to have viewers, patients, people that are in pain understand what are their options so you can really be able to make good choices about how to be able to help yourself and how to help those people that you care about. Today, one of the things that we're trying to do is really be able to give patients understanding about why you have some of the challenges that you do, particularly from a mood standpoint. And let's just be frank, a lot of times that's really not validated, it's not supported. As a society, it's like you hear these things like no pain, no gain. Okay, you know what? There's just a way for you to be a stoic and suck it up and get over it pretty easily. And truth be told, that's really kind of infiltrated into the ranks of a lot of healthcare. It's like, well, we really shouldn't talk about pain and how it affects people. Most recently, we've been dealing with a pretty significant issue dealing with opioid crises. And on a number of networks, meaning kind of like groups that deal with individuals that have pain, they have really been feeling kind of the challenges of the cracking down of opioids, but also seeming like there's an attack on pain patients too at the same time. And one of the things I wanted to do was kind of really try to be able to have a representation of what patients are feeling and then giving an understanding about really via anatomical, neuroanatomical representation, why there's truth behind why you feel what you feel and that there's a good reason for it. So let's talk a little bit about this from a broader perspective just for a second. There's an article that looked at living with chronic pain and how it can be able to disrupt your emotions at even a chemical level. And it goes on to really kind of get into the context of chronic pain is more than just an awful sensation. It's a neuroscientist that states it can affect our feelings, beliefs, and the way we are. A senior author of a recent study stated that using advanced imaging, they can use techniques to scan for concentrations of specific neurotransmitters in volunteers with and without a history of chronic pain. And I'll just kind of tell you, so one of those type of scans would be something like a PET scan that can really be able to evaluate that. But going on, it says that chemical in specific that they were looking at is something that's called GABA. So it's gamma aminobutyric acid, is one of the big players in brain signaling. And it's what allows for there to be a lid on neural activity across the nervous system. So specifically, this is looking at something that's in the brain's prefrontal cortex. So the prefrontal cortex is the portion that's kind of the front portion near where your forehead is. It's really key in cognitive processing. So it goes on to say, because of this, it can affect forms of traffic control, limiting communication with other regions, such as the amygdala, and it works in balances with other neurotransmitters like glutamate. And the signal system can impact really about emotions and how it keeps us motivated, but also how it can be stressed with various different issues, particularly those things like chronic pain. So for those of you who are joining, by the way, I really appreciate you joining us live. And for those of you who are catching this at a later point in time, please hang in with us. So again, what we're talking about is pain, depression, how the two relate, and how it's not just mumbo jumbo, but really giving you an understanding about why you feel what you feel. So as a provider, one of the things that I try to do is to attempt to put myself in my patient's shoes. I don't always do that great, which my patients tell me about fairly frequently, but still making the effort, I think, hopefully makes me a bit better. So I'm fortunate to be part of a number of different groups, and one Facebook group really has a support group for pain patients. And I get to see what they say in its nature. And so I want to kind of share that with some of the viewers on my channel. I've made sure that I didn't include anyone's name so that they have their own degree of respect and autonomy, and make sure that we're not giving out anybody's information. But I think the sentiment really should be echoed and pushed forth for providers to really know how patients feel. So I'm gonna give you a couple of different examples of some of the things that I saw. So this is an excerpt where a person says, "My father thinks that I'm making everything up. He Googles migraines and what triggers them. He then says I'm faking it because I'm eating something that Google said online is a trigger." And he complains and says, "Why do you have a migraine on Friday, but you can do whatever you want on Saturday?" And again, this is not to try to empower everyone not to make decisions and choices, but reasons why people have pain are not just limited to what someone can find on Google to then be able to say, "Hey, this is why you have an issue." Another was, "I was told by a physiotherapist that the pain was all in my head." And when you take a look at that and you actually look at what's the reflection on that, there's maybe 7 or 8 or other people who have a similar experience of that they've been told that pain is all in their head. Another individual says, "To distract my brain and think of something else." That's what someone told them. And how is it possible when pain overcomes your body that you can really be able to do that? And one of the final excerpts was the following: "I need to think positively and meditate, and apparently focusing on the pain is causing it." So a number of those things are really challenging, really, to be able to kind of take. Um, and most pain patients that I know are making an effort to really try to be able to be functional, not only for themselves, but for the people who depend upon them. And so when they get kind of that reinforcement in a negative way, not a positive way, that tells them that they're faking, that malingering, that this is really not that bad, that you can find ways to be able to overcome it. I think that there's some reason and rationale why you want to have positive reinforcement, why you want to be able to have kind of that aspect of hope, right? But at the same time, you also have to understand how dealing with that on a daily basis can just be so detrimental and such a battle and a fight. And many times we don't really have that honest conversation. So one of the things that is pretty evident and prominent is the following. So there's a cycle that takes place. By the way, let me kind of make a quick divergence. So a lot of our various different figures and articles, for those of you who are into the science and really want to know, are taken from 2 articles. One of those articles is within the Journal of Neuroplasticity, which was published in 2017. It looks at the link between depression and chronic pain and the neural mechanisms, and it really has been evaluated in full depth and detail. And the second article is one that looks at depression and chronic pain in the elderly, and it gives links and management challenges. To be clear, we're not talking about just the elderly, we're talking about patients as a whole, but these articles have figures that really give us an understanding about how the various different neurotransmitters and various different constructs are able to be understood in a simpler fashion, so that you don't have to have a fancy science degree, an MD, a PhD, in order to be able to kind of get what it is that we're trying to say. So one of those cutaways talks about the following: the relationship between chronic pain and the cycle that occurs. So one of the things that you have is this aspect of thoughts that then result in behaviors, would then result in somatic reactions, and then result in emotions, and it goes round and round, right? And so in saying that, it sounds very theoretical and not really substantive, or an example of like how that can be really put into place. So let me kind of give examples of what that really means. And I'm sure those patients that identify with this, or family members that see their person that they care about in pain, can be able to understand this pretty well. And that is, so initially you think, well, you know what? I have a pain in my knee, right? Let's say it's your right knee. And you're like, well, man, I got 5 different things I need to do today. Maybe I need to go to the grocery store. Maybe I need to pick someone up, in a car. Maybe I need to go up a flight of stairs in order to do, some various different housework. Maybe I need to do some exercise, and maybe I need to go out and get some grocery or something like that. What you very well may do is to say, you know what, before I do these behaviors and I go after and try and do all these different things, I think I'm going to maybe pick 2. Because I know if I try to do all 5, I'm going to have to pay for it. And what I mean by pay for it is that I'm going to have to hurt. And there's a level of how much hurt I can really deal with. If I'm trying to manage this both physically, mentally, not take all these different medications, be within my range and realm, I'm going to have to limit some of those things. And so accordingly, what ends up happening is saying, you know what, I'm going to reduce what I would normally do and see how that works for me. So there's some reactions to saying, you know what, I can anticipate this pain's coming. I'm going to limit that. And then accordingly, because I'm not going to do that, that may make me feel a certain kind of way, to use the kind of common vernacular. I feel a certain kind of way, right? And what that means is that you wanted to do all those 5 things that you want to be able to do. And sometimes you feel like, man, this sucks because I can't do all those type of things. I should be able to do it. I could do it before, but now I'm like, maybe I really just need to kind of buckle down and try it. And many times people will try it, but then they do have that sort of reinforcement in a negative way that their pain is just not letting them do what they want to be able to do. So this is sort of that theoretical construct of understanding how the two relate. Let's talk about a more involved way of how these things kind of relate. So an involved way of how these things relate are the following. So this is one of the figures from those papers that I quoted earlier that looked at various different interventions and how they might potentially be able to work. So the first thing that we talk about is something that's called neuroplasticity. So let me break that down as we try to do all the time on our various different videos. So neuroplasticity is the brain, the spinal cord, the nerves. They have the ability to be able to have this flexibility that exists. So for those of you who've heard about patients that have had, for instance, a stroke, and that stroke may have affected their speech or their ability to be able to use their dominant hand, and those neurons had an issue that were the ones that controlled it, there are other neurons that say, hey, you know what, we can help with this. And they're able to pivot what their traditional roles were and are able to now flex into the roles that are needed in order to be able to improve and regain speech and be able to improve that motor cortical activity of being able to use that hand. Neuroplasticity has that ability to cross multiple different things, not just those 2 examples that I mentioned, but other things. And so when we look at neuroplasticity, it's basically the context of how those neurons can be able to serve in different roles and what are the pathways that function that. Ironically enough, depression and pain have very similar pathways, and they also have very similar neurotransmitters. So when we talk about those things being activated, it's not all that unusual. So for instance, if you're driving along a highway, whatever you want, I-95, I-94, 65, pick whatever you wish, and you know you're going in one direction for one, it's not all that uncommon that you might then have a subsequent destination that's along that same pathway. And it's not because you're not tough enough. It's not because you're not stoic enough. It's because that there are similar pathways, neural pathways that can certainly have ectopic elements that are present to it. So what I mean by that is when you have those spikes of pain that can occur from time to time spontaneously, it's because you have certain things that drive that. There are firing things that take place spontaneously within the nerves that give you some of these issues. And so when we look at that, could you not then have that from a component of depression or anxiety that you're really like, man, how is this stress affecting me? And I'm not able to kind of modulate that or kind of keep it under control. So we go back to that piece and we look, we can see that there's this element of looking at this broader component of cognitive regulation of that using psychotherapy, and then neuroplasticity, where there's an interrelation between pain and depression. This particular article is talking about the treatment of chronic pain-induced depression and what are some of the things that can be able to be utilized. And so you'll see different treatment options like monoamine oxidase inhibitors. We're going to talk about that. Tricyclic drugs, selective serotonin reuptake inhibitors, glutamatergic drugs, benzodiazepines, and opioids. And what are the targets that they work on? These targets are really the important things because they are the molecular mechanisms behind how both pain as well as how depression can be influenced. So this gets complicated real quick. But at the end of the day, when we look at monoamine neurotransmitters, when we look at BDNF, which is brain-derived neurotropic factor. When we look at inflammatory factors and glutamate, they have similar roles. And so one of the reasons why I'm presenting this is not to sound fancy and want to use big words to impress you, but more so that you can have an understanding. There's certain medications that we've used, and there's certain pathways that we're looking at that may be able to be triggered or inhibited in a non-invasive way that can give you pain relief and at the same time be able to help improve your mood. So we're improving both your pain, the nociceptive component of what you feel, and be able to improve the emotion of the hesitancy that you would have because that pain has made you say, you just can't do what it is that you want to do. So for instance, when we talk about the construct of MAOIs or tricyclic drugs, right? There are certain medicines like an Elavil, right? So Elavil is a medicine that's an old school medicine that has been used for depression, but right now it's used with some degree of frequency for individuals that have nerve pain. And so when you have nerve pain, as opposed to using something like gabapentin or potentially Cymbalta or Lyrica, you could be able to use a construct such as that to be able to give relief. And the question is how does that happen? Because if you can be able to use it for that, how did you be able to use it for the ability of being able to improve overall mood? So let's talk very briefly. It gets a little wordy, so bear with me. But monoamine oxidase inhibitor, let's just take a quick read of this and kind of take out the big pieces and really kind of, to use an analogy, eat the fish and spit out the bones, right? So in essence, they have been an efficacious antidepressant, though they're not used quite as much as what they had been before. They're used in treatment of a number of different other conditions. There are reversible inhibitors of monoamine oxidase inhibitors that are used clinically in treatment of depression. And at the end of the day, new research has been able to kind of show that there are some side effects that occur with them, that they can be able to have various different impacts based off of dietary reactions. And some psychiatrists, what they utilize them as a last line of treatment when other classes of antidepressants haven't been effective. And so traditionally they'll use things like SSRIs, right? And so when we're talking about using a monoamine oxidase inhibitor, it may fit into the category of something like this. So when we look at it, it can be able to affect different things like serotonin and dopamine release. And those things can be able to impact our overall mood. The same time, you can look at things like that previously referenced BDNF and how it can be able to affect it. And this is within the construct of using opioids, but it does not need to be an opioid agonist to be able to do this. You can do this with other types of things. And when we look at kind of that piece that looks at BDNF and we look at depression, for example, BDNF is something that, again, is that brain-derived neurotropic factor. And what you can see is that with stress, it can have a change that takes place. And that change affects how neurons function. As we mentioned before, there are things like glutamate that influence how nerves work and how the synapses work. And those things can immediately result in depression. And so when we talk about that, that's very seldom mentioned when we go back to these constructs of looking at, like, for instance, that aspect of the various different issues that are going on when we have Facebook individuals that say, you know what, I'm just told that it's all in my head, that really doesn't exist. And how can we be able to adjust this? Well, there's neuropathic physiology that's going on that really is affecting people. All right, so we have a question from one of our viewers. Our question is the following: how would a person go about getting those medications? Would they have to go to another doctor to get them? Well, first and foremost, as I'm talking about all these different things, let me be clear. Number one, I'm not saying that you need a medication for this. And I'm not saying that every person should have a medication for this, right? First and foremost, what I want you to understand is that there's a neural mechanism behind this. And I really think patients need to understand that because you have pain, that does not invalidate how you feel. And without kind of touting our own practice as the best practice out there, I think we do some things good, but I think there's some things that we can do better. We try to have patients use an app called NeuroFlow, which tracks your depression and anxiety. And one of the reasons why we want to track that is because there are days, even for people who have really intense pain, where you have good days and you have bad days, as we know. And what we want to do is to kind of correlate that to how well are you able to function, as well as what was your pain like that day. Because not every day that you have bad pain means that you can't function. And not every day that you have a little bit less pain means that you're functioning really well. We really want to be able to have you look at that, reflect at it over a number of weeks, months, and years to say, okay, hopefully we've eliminated the pain within the construct so it's not lasting that long. But if we haven't, then how is that affecting you so you can really be able to take a look at it, identify it, and say, yeah, this is causing me more problems than what I was willing to admit. And particularly for some of my guys who are not always that in touch with what's going on with them, to be able to see it quantitatively and say, hey, you know what, this is actually affecting me. I need to be able to kind of figure out how I can be able to address this so I can be more functional and I can really be able to have a better quality of life. Do we want to pick a medicine to be able to kind of deal with that? Maybe, but there are times where we say, you know what, I think we can be able to deal with this in a different type of way. I can tell you right now, there are things that we do and what we're trying to do to be able to influence that. So for instance, one of the things that we're doing in our own practice is we're doing things like ketamine to be able to improve that, right? And so if you're interested in talking about ketamine and how it can maybe be able to potentially improve it, drop us a call or shoot us an email. Or if you're on our doctor plan program, then shoot us a secure text message. But at the end of the day, this is not about trying to sequester patients to do what it is that we do. What we want you to understand is what's the value of knowing your pain and depression and other mood stability issues are interrelated. So kind of going back to that article that talked about brain-derived neurotropic factor, there is also a way that it interacts with causing problems that will cause you pain. And so these different neurotransmitters like GABA and glutamate, they have a direct effect on nerve function. And so one of the things that we see previously is we've looked at things like NMDA receptors, so things like N-methyldeaspartate, so different medications that kind of treat those type of things are going to be things like Neurontin, also known as gabapentin, or Lyrica, or ketamine within the construct of what we have kind of listed below, right? So those things have effects on the NMDA receptor, but at the same time, that receptor is influenced by how things like glutamate and GABA are present within our nervous system. And the same token, for those of you who know interventional type treatments, that's one of the ways in which those changes in those neurotransmitters are efficacious in helping spinal cord stimulators be able to work. And so when we look at how this all kind of is intertwined, what we know is that there are not only the neurotransmitters, not only are there elements that are present in the brain, but there's also pathways from the spinal cord to the brain that are both similar and kind of synergistic in pain and depression concordantly. Meaning, so for instance, there's a pathway that is affected in a positive way by a certain type of spinal cord stimulator pattern that is believed to potentially improve mood at the same time as improving pain. And vice versa, if that pattern is not there, obviously you can kind of expect that conversely, it can potentially be able to worsen it. Right? So if I was speculating, which I know I have a number of patients that say, okay, well, if we're not going to do the medicines, then what could we do in order to be able to improve this? First and foremost, I would probably say, let's talk about what can you do naturally to try to improve this. So within one of the comments I think was made was from a dietary standpoint, are there things that we can be able to do? Prior to dealing with the dietary piece, I think first is trying to make an assessment of, do you have different vitamin deficiencies that might predispose you to having different changes in what your neurotransmitters might be? And that's something that actually we're doing in our own office for those people that are interested. It's a little bit more involved. It takes a little bit more, I wouldn't say know-how, but a little bit more effort for the practice to kind of do to evaluate, to really identify for patients and individuals where this just has not been something that has been a quick response. Can we identify what's going on with you? And can you then kind of take control of that and deal with dietary influences to try to be able to improve that and limit the degree of impact that those neurotransmitters are going to have on you? One. Two is, yeah, there are ways for us to look at medications, but we want to see, do those medications have other side effects Do they cause other downstream type effects that can cause problems and issues? But we don't want to just say, no, 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 no. We don't want to use this at all if it's a possible solution and option. 3 is, can we use other things which really haven't been as well defined, but can see that they're on the cusp of bringing more and more relief? So things like ketamine, things like transcranial magnetic stem, can we be able to get an assessment either with PET or quantitative EEG to understand what's happening from both a pain as well as from a depression type standpoint, so we can be able to be ahead of it? And that way, when we're talking about neuroplasticity, which is again the elements of the nerves kind of adjusting one way or the other, we can let those nerves adjust the way they want, meaning increased pain and increased depression, or we can try to see if we can influence that to have that elasticity go the way that we want them to go, which means less pain and less depression. And there are different things that can be able to do that, whether it's the construct of an infusion or whether it's the ability to be able to use different types of energies to influence the brain, spinal cord, and the downstream regulation of how those nerves talk to one another, to whether we generate different types of nerves and connections to be able to have that function in the way that we would expect, to being able to influence what neurotransmitters are limited in their uptake, so we have more present within the synaptic cleft. All those things make an impact on how we can be able to provide relief. Okay, I think we got a few more other questions that are coming in. Are you currently doing study groups or looking into doing them? So really great question. I really appreciate that. One of the things that we're trying to identify is, are there patients who are interested in that? And we've talked about this for probably greater than maybe a year and a half or so. And I'm curious further within that comment that you just made is whether we need to divide this up so people that have similar experiences feel like they can talk to someone that can understand them. And do you want to do that in person or do you want to do that virtually? So for us, as many people probably know, our practice has really leaned into kind of the virtual experience because it, number one, respects patients' time, but number two, it allows for us to be able to coordinate across distances. So in terms of being able to deal with kind of support groups, I think that's one thing. From a study standpoint, I think there's some things that we're looking at pretty aggressively of how we can be able to try to impact patients, whether that's topical application of systems, so things like Qtenza or things along those lines that we've talked about in other talks, or infusions or non-invasive neuromodulation type therapies. Okay, and then I think there's another statement less than a question. I think it would be a good idea. I got you. Okay, so we will do our best to try to see what we can do about making that happen. What I would say is I need input, and I need input from just more than one person. I need to know who wants to be part of a group, and do you want a support group? Do you want research, kind of connections to research, even if it's not our office doing it? Because we don't really care about whether it's us getting you better. We just want to have a way for you to be able to improve where you're at. And if we can do those things, that's really kind of our purpose and our mission. So, but getting back to kind of the course of this talk, what we really want patients to understand is that there is a connection between how pain pathways work, how depression works, and that we want to be able to kind of limit this continual circle of having those thoughts that dominate our behavior, our reactions, and emotions, and really kind of break that cycle by not just saying, okay, we got to be able to deal with the pain, but we also got to deal with the other part of that, which is the mental component, but not just give these kind of platitudes of saying, yeah, you got to outthink it, or you just got to gut it out, or you really just got to kind of put mind over matter. Not to say there's no value in mind over matter. There are some strategies that can be very helpful. A lot of different strategies, as a matter of fact. But we also need to understand that there's a neuroplastic level or plasticity that is occurring that can be able to cause those problems and issues. Okay. So if you have questions or comments about this, please leave something in the comment section. We really want to know if we need to lean into this a little bit more. Our gut or visceral reaction is yes, because we just don't think that there's really enough validation on it. And from what we've seen on social media, there's a number of patients and individuals that really have challenges with the healthcare system as a whole, in terms of having pain that's present and then being told, no, you don't. And so trying to find a way to really be able to provide answers, not just somatically, meaning kind of the underlying levels of the experience, the actual physical piece, but also figuring out that emotional piece, tracking it, assessing it, improving it, and figuring out how much we really were able to make an impact. Because the pure fact of the matter is, if you don't figure out or analyze what you have, then you can't figure out how much better you might be doing. And again, for those of you who joined us, I know this is a long-winded kind of esoteric topic, but I think it's an important one. Really appreciate you joining us every week. And again, if you want us to kind of go into more depth and detail about this, please leave comments in the section below. And thank you so much for your time and have a great day.